So what I'm going to share with you a little bit about the second victim. You know, the title was looking out for ourselves, but we have to take a look at this. So what are the goals? We're going to take a look at some of the issues that are associated with some jobs' dissatisfaction with the practice of anesthesiology. We're going to apply the concepts of the second victim, and we're going to take these home to our practice to see how we can help our colleagues after an unanticipated adverse outcome. We're going to take a look at some of the effects of stress and its links to substance abuse, and recognize that all it takes to change all this is one person. And I think that's absolutely amazing. I think that's one of the things that was the focus, and what a superbly put together panel this morning, because each of us really is going to touch on it takes one, and the one person is you. You know, to leave here realizing you can have a big influence on your practice. So where we're going to go, we're headed to infinity and beyond. Okay, so is anesthesia stressful? So the answer is yes, it's very stressful. So how do we measure stress? Well, we can taking a look at mortality. So let's look at deaths amongst anesthesiologists, and I apologize to my CRNA colleagues out there. I tried to find the literature on that, and I couldn't find anything on that one, but I did pull this one study. So they looked at anesthesiologists from 1947 to 1966, so it's old. And they compared it, and they identified 441 deaths, and they compared it to US men in that insurance company. What did they find? That the incidence of death of suicide by anesthesiologists was twice that of the general population. So when we look at that in the general population, the fact is, by being an anesthesia provider, you have twice the risk of suicide, at least in that time period. And that was most likely to occur in the young. You know, it's those people who just finished their training and are starting their first job. However, we're sitting there saying, but Bob, that's 1947 to 1960. Come on, why are you getting so much old data? So you're right, that is old. So let's take a look at something more recent. So let's look at the physician master file. And this time, rather than comparing it to the general population, what this group said is we're going to look at anesthesiologists and compare them to internists and see the impact. And we're going to look at the time period to 1979 to 1995. So very, very recent in that time period. They found a significant number of deaths, 2,500 deaths of anesthesiologists, 2,300 deaths of anesthesiologists. And again, there was no difference in the risk of death from cancer or heart disease. So that's great. This exposure to all the inhaled agents, this exposure to the radiation that we get exposed to in the OR, it's not increasing our risk of cancer. However, the rate of death of suicide was still 1.5 that of internists. We have a greater chance of having death from suicide than our internal medicine colleagues. And drug-related death, look at that, was 3 times. So we do have a problem here. And the fact is that anesthesia providing is very stressful. Anesthesia providers are very stressed. When you think about it, our job is extremely stressful. You know, we have the time constraints. We heard a little bit of addressing of turnaround, but in our institution, we get a phone call. Our start time is 7:30. If you do not have the patient in the room and induced by 7:30, you get a phone call at 7:35 asking why. And it's coming from your colleague. And I'm sitting there saying, well, you know me, and I really get my cases started, so can't you just assume that it was a patient delay, or this was a really complicated case? But we have all these time constraints. We have an excessive workload. We're asked to do a lot, and we're allowed to be thinking about it at that time period. It is a complex task. You know, there's no question about it. And it's amazing to watch as you go through your training. You know, if you try to remember where you were at the beginning of your training, at the end, how you've assumed that complex task, and how you don't realize it until you start working with residents or SRNAs, how much it takes to get there and the amount of learning involved. We always have this responsibility to the patient, and deep down we still have a slight fear. Anytime I induce, anytime I'm doing something, there's always that fear. You heard that when Michael was talking, and he says, you know, when he's getting ready to do that epidural, and it's the video, but it is. We always have that little bit of fear. We don't want to harm people. We don't have much control. You know, boy, do I see that all the time, where you're there, you know, you want to get out, you had made this appointment, you promised your kids you're going to be there. You can't be there because the case isn't finished. It's going long, or they just need you more there. And you have to take call. You know, I still find that amazing. My mom still hasn't figured out that I take call in the hospital after 25 years. What do you mean you're not coming home? And what do you mean you're not home for Christmas? Mom, I have to be in the hospital, and the stuff. And that's mom. What about the kids that are looking and saying, Dad, why aren't you home for Christmas? So there's a lot of there. So when we take a look at a study of Belgium anesthesia providers, what were the 3 things that they identified as the biggest threats, the most stressful aspects? And it came right off that list. So the key to that list, we're going to narrow it down. And they said it was the lack of control, this inability to feel that they have a sense of their control of what they can do and be there. Difficulties in communication with surgeons. Boy, if that wasn't nicely addressed by Lawrence with that. And then the time constraints. Constantly, we live under a clock. Absolutely amazing. Just think about it tomorrow when we're going back to work and you've gotten your first case, started, and you realize that's when the rest of the world is just arriving to work. It's pretty interesting in that one. So we have a lot of these time constraints. So what they said is take a look and think of these stressful situations. And the ones that they said the most stressful for you will be medically difficult. You have these challenging patients, work overload, or difficult ethical decisions. We're constantly confronted with those. And what's the threat from that? We have to realize that we're always worried about an unfavorable outcome, and this generates these negative emotions. And the key to that is taking that, and instead of viewing it as a threat, viewing it as a challenge. Because that will generate going from negative emotions to positive emotions, and it'll allow you to mobilize coping strategies. Why do we so worry about stress? Well, it's because stress leads to burnout. We get tired, and it's just burnout. Here's a survey, so the Malish Burnout Inventory. So it's a survey that's given, it assesses the degree of burnout of the individual. And what they did is they took a look, and in this study, they took a look at residents, anesthesia physicians, and operating room nurses in this one. And so you can see they had 145 respondents, and there's the division up. So what did they find out? So it turns out that in this study, at least in these operating rooms, that the physicians had a higher chance of burnout than the scrub nurse or the circulating nurse. And if you were to compare the surgeons to the anesthesiologists actually had the higher risk of burnout. And if you pulled the things, it was the residents. The residents actually had the highest risk of burnout. They scored highest overall, and they were just emotionally exhausted in that. So what I'm going to take you to is a day, and it's funny because you sit there and you look at that date, and right now, I can't tell you what the sensation is going within me now when I saw that date, and that's a picture of our hospital, because I already felt my heart rate increasing, and I started to feel my palms, because I'm going to tell you what happened on that day. So I was covering labor and delivery on that day, and it was a Friday, and I really remember this going in, and so it was around 3 o'clock. We had a woman with a placenta previa and 1 previous C-section history of cocaine use. I gave a push to go down to the operating room because my concern was that there was a concern regarding accreta in that regards. But our obstetricians pushed really hard back. So I'm pushing, they're pushing, and they ultimately won. So now the case is being done on labor and delivery, and the decision was that we would use an epidural anesthetic. So we did the epidural, and of course there's an accidental dural puncture during the epidural, and so now she has a continuous spinal anesthetic. Continuous spinal anesthetic, and everything went reasonably well for the case when we're talking up until a certain point. So everything's done, uterus is out, so I had to go to gravity hysterectomy, 2-liter blood loss, patient is communicating. We decided not to intubate because we felt reasonably comfortable. She started to complain of a little pain and the bolus, the intrathecal catheter. And she's still talking, and all of a sudden, very silent. Very silent. In fact, the pulse ox, if we had noticed, had stopped going. And if you looked at the record before, there was a bradycardia, and then it went to complete asystole. So we end up securing the airway. We initiate CPR. We're able to get the heart rate back. We administer epinephrine. We figure it was either a high spinal or this Betzel-Jerish reflex, leaning more toward the reflex because she was still also moving her hand right before, and secure the airway. And we go see her the next day. And of course, she's not waking up. They do some imaging, and she has anoxic brain injury. So I sat there, and I'm like, Oh my goodness. And then the only thing I remember is that, sitting there that whole day, just going every day, just checking and seeing, is she going to get better? Is she going to get better? Well, then next day, so we're now on Monday, and I'm covering labor and delivery. And I go on labor and delivery, and I didn't feel so good. I sat there, my heart was beating. I just didn't feel right. And so I ended up calling, and I just went home because I said, must be coming down with something. Tuesday comes back, and I go on labor and delivery, same feelings. And I went right down to my chairman, and I said, I just need to talk. And, I will always be in debt to Dr. Moravchik to this day, because he sat there and he listened to me. And the biggest thing he did is he sat there, he said, Bob, you got to get some help. And I was able to get some help and get me through this situation, because I was really having a very bad stress reaction to this, to the point where I really was considering leaving the specialty. So in 2001, after paying all of medical school, after all of doing residency, I really was ready to quit. And the question I was then confronted with after all this and addressing this, is this unusual? The answer with this is no. Here's a survey sent to 1,200 ASA members, 695 responded. So of course there's always going to be this bias that people with this might choose to do it, but it's a reasonable survey. 84% had at least one unanticipated death or serious injury, and that's just one. What was the impact of this? When we look at this, greater than 70% experienced guilt, anxiety, and reliving the event. And I'll tell you that, I already saw that. When I saw the 2001 date, and I knew I was giving the talk, and this day I can still see the patient, I can still see everything about this. You never end up forgetting these things. It's always there with you. But there's that guilt and anxiety. 88% required time to recover, 19% never recovered. 1 out of 5. 1 out of 5 of these 600 or 700 people never recovered, and 67% felt the inability to provide patient care was compromised for at least 4 hours, and 7% never given time off. And my goal is still, and I work so hard, and I get the residents out, but do you know what our place does if you have an intraoperative death? The first thing they do is they put another case in the room. And they're like, come on. And it's no time off. And yet because I'm the residency program director, so I make sure I get the residents out. The poor faculty, nobody's looking out for. And I really have a big problem with that at our place. What's the response to the first thing with an intraoperative death is put another case in the room. And this is a problem. So when we look at this, of these number, 132 never recovered, and 83 thought of a career change. Again, let's take a look at these incidents of this problem. Here's a survey sent to 300 physicians in the United States and Canada. And you can see 7% had a near miss, 36% minor error, 57% had a serious error. So it's all going to happen in our thing. We're caring for sicker and sicker patients. My residents laugh. Those my age and older, do you remember the too sick for anesthesia? For the young people in this room, you don't know that. But believe it or not, we could go in the, I remember when I was finishing up in 1991, writing on the chart, too sick for anesthesia, and the surgical procedure wasn't done. That's not so anymore. Now it's just, we keep getting sicker and sicker patients, and we're going to have these outcomes. And when we look at least in this series, the increased anxiety, there it is, the pointer. You can see 61% decrease in job confidence, decreased job satisfaction, increased sleeplessness, and harm to the professional reputation. It is a problem in our specialty. How about the impact of a maternal death? Here's a postal survey sent to obstetric anesthesia providers in England. There was 706 respondents. 291 had a maternal death. So when you think about it, it is quite a problem out there. Of the 706 respondents, now again, there's a bias, because if you didn't have it, you might not choose to respond, but that's a pretty significant response rate. 60% received no support. The most frequent support came from a colleague. 5 people developed depression, and 2 people left the specialty completely. So 2 people said, I'm done. I can't handle this. So it really is a problem. And I think the key to this is we need to change the culture. One of the recurring themes of this whole panel, this really nicely elegant panel, is changing the culture on your labor floor, changing the culture in your hospital, changing the culture in your group. What do we have to do? We have to look out for the second victim. So what is this? This was a concept that was recognized as I was investigating my situation. So the first victim is the patient and the involved family. So there's no question about it. I'm not trying to downplay it, but what we also have to realize is that the second victim is the healthcare provider. Healthcare provider is this one who's been involved in an unanticipated adverse patient event, medical error, or patient injury, who really does become victimized. They relive the event. This is going to affect their care, going to affect the way they care for other patients. And some people say there's the third victim, and the third victim is the patient who that healthcare provider who had that bad outcome is asked to care for a patient. So when you look at it, that second victim has a significant impact. And when we look at nearly half of the healthcare providers will experience this second victim at least once in their career. You know, I'm not going to ask for a show of hands. But I would guarantee if we asked, I would probably say to venture at least all of us would be able to raise our hands because we have been involved in an unanticipated adverse outcome. And it does have a significant impact on ourselves. So how does the hospital handle this unanticipated adverse outcome? Well, the first thing you've got to do is you subject yourself to a root cause analysis, which is important. You know, the way to identify and treat errors is to identify them and correct them. What's the problem with the root cause analysis? Well, it really doesn't help the victim, you know, the provider, because there's nothing in there that's going to be talking about the person's feelings. Because what happens when there is this unanticipated outcome? You feel personally responsible. Even if you're not, try to convince yourself of that. I still can't convince myself that I wasn't personally. In my head, I'm constantly going, well, what if? What if I had done this? What if I had done that? What if? And then you start questioning your judgment. Maybe I didn't use the best judgment. And, you know, it's trying to be, and of course, your friends are going to be very helpful when you talk to me. Well, I wouldn't have done it that way. And it's easy to be a Monday morning quarterback. You know, it's very easy to be a Monday morning quarterback, and thank you for helping, but you're not helping me. You know, this was the thing, and we have to be there and listen for this. They feel as they failed the patient. We let the patient down. The patient trusted us. You know, they trust us with their lives. And if there is this outcome, of course it's going to have an impact. And you'll start second-guessing your knowledge and your skills. Here's taking a look at the incidence of the concept of the second victim. 78 studies identified, and you can see the incidence in the literature is somewhere to about a third, to give us an idea. So I already talked about the root cause analysis, and the problem with that is, I mean, it's perfect. We need a root cause analysis. There's no question about it. Patient safety doesn't move ahead if we don't have that root cause analysis. We can't fix errors in the healthcare system. We can't fix errors in anything if we don't have it. The problem with the root cause analysis, there's at no point do you get to discuss your feelings. You know, it's really trying to identify the error, but that's not helping the person who's had it. So don't think the root cause is going to do anything. In fact, sometimes the root cause can make it worse. As they're sitting there saying, well, you know, the system was broken, but shouldn't you have identified it? Yes, you know, you should have pushed harder for doing that case in the operating room. Would it have made it? I don't know. But of course, in my head, I'm thinking that. And that is one of the problems with all this. And then the first thing when you talk to management or the hospital lawyers, you had this bad outcome, what's the first thing to tell you? Don't talk to anybody. You know, why? Well, because anything you say to anybody is discoverable. Well, wait a minute, how am I supposed to help myself? And that's where I was eternally grateful to my chair, who sat there and got me help, because I was able to talk to a professional, and in that case, you had a privilege, and I was able to share in a non-discoverable fashion. But it's really scary. You want to share with your family, but the first thing the lawyer is going to tell you, don't share, because anything you say can then be discoverable. And that was one of the benefits, having talked to a senior advisor on this who could help guide me the right way. And, you know, it really is the lawsuits, then when you get that, they're just emotionally damaging. So how do we help the second victim? How do we address this? Well, we got to realize that there's going to be first chaos and there's this accident response. So, you know, there's this really trying to figure out, and it hasn't even settled in. Nobody's had a chance. Then starts the reflection. Then starts the going home as you're trying to sleep. Well, what happens if I had done a general anesthetic? Why didn't I push harder for doing that case in the OR? And you just constantly in your head, those questions will play over and over again. And it's always the what if. What if I had done this? Then you can hopefully, the real correct step is to support, restore your personal integrity. But the hard part with this is the enduring inquisition, the asking, the root cause analysis, the meeting with various administrators. All that stuff is going to follow, and we have to be aware of that to help our colleagues. And then with some emotional first aid, we will recover, but if we don't, we got to figure we're going to move on or drop out. So what's one of the problems with all this? Well, we already can figure it out. It can lead to substance abuse. So here's some of the most recent data and the problem in this. And so let's face it, there's absolutely no question. The highest incidence of death for anesthesiologists is substance abuse. The highest incidence of death for CRNAs is substance abuse. And if you look in the literature, it's really clear too. The highest risk of death, at least in the young, for oral maxillofacial surgeons is substance abuse. Anybody care to guess why? Part of their residency mandates, they do 6 months of anesthesia. So once you expose them to the anesthetic, it's true. They get it because they know where else in the hospital can you get the substances without having anybody look at you? You just go in the Pyxis and you get all this fentanyl and then you return a little bit of saline. That's the problem with it. And so what is that leads to this? It's the stress. 4,500 anesthesia residents, 1,000 were identified having a substance use disorder. When we look at substance abuse, we do have to realize it is mainly in the under 45 population. After 45, the substance that's most commonly used by older providers is alcohol. There's why this is a problem. Amongst those detected in residency, 1/3 will relapse. And of these, 6% will do retraining, and 1 out of 10 is going to die from this relapse. So let's get an idea of the problem. Is this really a current problem? Here, May 24th, 2014, a drunk anesthesiologist was pulled over for speeding in Florida. And the reason this got the news was because somebody was videoing the anesthesiologist pounding their head against the car until it was bleeding. So if you Google it, you can find the video of it. I didn't bring it up. October 4th, 2014, a drunk anesthesiologist intubates the esophagus during a cesarean section. The patient dies. October 2014, last year. Check the news. And it was clearly an intoxicated anesthesiologist. And how about this? If you watch the TVs, here's Grey's Anatomy. And during this craniotomy, the surgeon, who can do everything, by the way, this surgeon does everything. So now we're doing neurosurgery. I think the case before was an appy, and now she's doing a craniotomy. And the anesthesiologist sound asleep, and what you can't see on this film, intoxicated. And that's what the public is seeing. It is a problem with this. Stress affects our well-being. 26 residents from anesthesiology medicine. If you're not attending to your well-being, it's going to affect your relationships with patients. Going to be as good. It's going to affect your interactions with colleagues. Boy, didn't Lawrence point that out nicely with that surgeon. And when he went and investigated, why was the surgeon having bad interaction? That surgeon was stressed. And if you're stressed, you can't have good well-being, and you're going to have poor interactions, and it's going to affect your motivation. So if we can figure out a way to address this, we can figure out we can improve our relationships with patients, with colleagues, and our job satisfaction. So how do you help the second victim? I think the key is time between the event and the support is crucial. The one thing we have adopted in our department, I'm happy to say, is we do have a second victim support committee. So there are people on, they're always available, and if there is a bad outcome, the provider is allowed to contact these people, and the way I understand it from medical legal, because they are part of this committee, they can share in a non-discoverable fashion. The key to this, too, is it has to be senior members, because it is really helpful. For me, it was really, really helpful to talk to my chair, somebody above me that could help me through this. And I think the key is empathy. I didn't need sympathy, I needed empathy. I needed understanding. He listened, and that was very helpful. Inquire about the colleague is really the key to all this. And hopefully that's what I want to leave us with, that we come away from this realizing that if there is this bad outcome, let's help our colleagues with this as they go through this. So how do we help them? You encourage self-care, recommend counseling. I think it's critical. Recommend any community resources, and it's really not a simple answer. It's not this was God's way. That doesn't help. It's the talking, and really it's not even talking. It's just being there and listening. It's probably the most important aspect. So here's anesthesia's secret. Let's face it, anesthesia providers are human. There's no question about it. Anesthesia providers are really, really deeply affected by a bad outcome. We've all been there. In our heads now, we're thinking about them right now. We relive them. They never really do go away. We have a choice when we have a bad outcome. It can really be the end of a career. A poor SRNA who's invested, or a CRNA who's invested all their money in training, anesthesia resident who's invested all that money in medical school, has a bad outcome, and they're going to stop doing that after this? That's not a wise investment, especially when it can be easily solved by just being there and caring and helping them. And I think that's the problem. Here's the responses. It can be quitting, substance abuse, suicide, or recovery, and it's all determined by you. So if your colleague has it, I think the most important thing is to be there for them. You can make a difference. So in the end, when you're at the end of the day, when at the end of a bad outcome, the end of the career, what is it that we want? We want a hug. So, and you can see here is the end of the Disney Marathon, and nothing's better than getting a hug from Mickey. With that, I say thank you very much, and I invite you.